AVMs are like the ones that you do, your renal fistulas. If there's a thrill, you would think that clinically, you think more of an AVM than a hemangioma. Okay, because if not, there'll be the shunting, and you see these large veins surrounding it as well. So ultrasound can help, but sometimes it can still be difficult to differentiate. Okay, so you always, or at least for us, because we are not a surgical center for them, we refer it on. Okay, next one.
This is a frontal and lateral radiograph of the femur showing a hyperdense area in the dorsal aspect of the proximal femoral shaft. Okay, on ultrasound, this is heterogeneous with central hyperechogenicity within. This would be a calcified lesion like soft tissue neoplasm. There's no involvement of the underlying bone.
Okay, so I'll give you more history. So there is a bit of like, okay, and not much of soft tissue changes, but a mom says when the patient gets, when it's particularly active, using the limb a little more, you notice the swelling gets bigger, and then it goes back down in size. It's kind of intermittent swelling in the region of the middle thigh, and then you look a bit closer, you wonder if there's some calcification within the soft tissues here. And then perhaps this could relate to this.
If it's reducible, then it could be a.
It is compressible as well. It's compressible on ultrasound.
So this could be hemangioma again with the phlebolith.
Yeah. So hemangioma, as I said, is a vascular tumor. Okay. So I think if you wanted to say, so yes, so this is not a hemangioma, but this is the other side. They are called vascular malformations. And I'll explain the difference in a bit. So you're right, these are phleboliths, and the reason why I gave the history, so they are usually they are just dysplastic vessels, okay? It can be lymphatic vessels, it can be venous vessels, normally, or mixture of venolymphatics. Unlike hemangiomas, which are tumors, these are more ill-defined, and they also demonstrate very low flow. You can sometimes get some papers say you can get a bit of arterial flow, but generally they are really slow flow. So you've got to turn your Doppler settings down or use power Doppler to even pick up a little bit of flow. And the giveaway sign is the phleboliths within it to suggest that it's very low flow. The reason why I mentioned the history is because if it's a venous one, often you get intermittent swelling when you use the limb just because of the diversion of blood flow through these spaces. And if it's a more lymphatic one, then these would often swell when a person's unwell or the patient's unwell. Okay, so the venous one a bit more dependent on activity. But the lymphatic ones often when there's a change in your lymphatic system, so like when you're unwell, a general rule. Then going on to MR. So when you see that, some people, or rather some clinicians, if they wanted to operate on it, because it's very extensive, they'll ask you to do an MR. And MR just shows you, so these are the post-contrast pictures, and the post-contrast and pre-contrast ones showing just cystic spaces or cystic signal ill-defined lesions, but they just look like quite bubbly. And in post-contrast, you can have a bit of, even if just depending on how delayed you acquire these images, you can get enhancement within them. Okay, this is more on a difficult spectrum, but it's just to complete. If we're talking about hemangiomas, then we need to talk about the vascular malformations as well, but it's unlikely to come out with exams. So I think, as I said earlier, the vascular malformation is more of a vascular dysplasia, so it's a dysplastic channels, or hemangioma. I think we hadn't gone to that slide, sorry. Oh yeah, so I needed to do this, sorry. Or hemangioma is more of a vascular tumor. So vascular malformations can present at birth, and it grows with the child. Okay, sometimes it can involute, sometimes it doesn't have to, and it's one of the most common in the venous ones. The venous forms are the most common vascular malformation. And we said earlier, so soft tissue mass phleboliths. You can sometimes, because of the change in blood flow in that region, you can have periosteal bone formation. I really haven't seen that. Vascular channels, large cystic spaces. You can have these like fatty type connective tissues intervening or cystic spaces. And you can, often it's more low flow than high flow, and Dopplers want to help you to identify the flow or in waveforms, and MRI if surgical intervention is considered. So this is one of the easy, this is the way I think about it. I think there's an ISSVA classification from 2014, but vascular anomalies, if you're not sure what it is, that's the umbrella term. And then if you go into, you can then subdivide it into hemangioma or vascular malformation. And then hemangioma, again, more tumor-like, vascular malformation, more ill-defined area of dysplastic vessels. And you can then further subdivide it into, so clinical assessment is important, okay? Because history helps you to go down one or the other path, and then following that you can then split into either AVM, so often use the thrill, or you can see the very large veins because the AVM, venous malformations, I said, lymphatic or combination of both. Capillary malformation we don't often ultrasound because they are clinically diagnosed as with the skin changes. Okay, so if you have, the only thing is that if you have capillary malformation, often what you do is you do brain imaging because you want to exclude a Sturge-Weber syndrome because it's higher risk. Okay, so last few slides now. Candidate 4, last slide.
Okay. This is a surgical ultrasound image of the left leg in the plantar aspect. There is a heterogeneous area in the plantar aspect of this image. I'm provided also with MRI. MRI is showing T1, which is hyperintense. On T1 fat saturation, this is partially suppressing, and on T1 post contrast, there are some internal enhancing septate. So this could represent due to incomplete suppression and some enhancement. I'm thinking of a liposarcoma.
Okay, so this is a lipoma. Before we go there, can you tell me why you think it's a liposarcoma?
Because it was not completely suppressing on the suppressed image. Also, there was some internal enhancing septate on the post contrast. Okay,
so in lipomas, you can sometimes get a little bit of internal enhancement. So on ultrasound, you can have a little bit of internal vascularities, and you can also sometimes get a bit of septations. I think what's more, if it was a liposarcoma, then things that you're looking for is nodularity, of course, enhancements of that nodularity. But just also remember, this is in a child versus an adult. A lot of those criteria, although it can also be applied to a child, but often are applied in the adult population. In a recent talk that we went to, the most common type of liposarcomas in kids are myxoid liposarcomas. And because it's myxoid component, often looks very cystic. If we go back to this ultrasound, it actually looks quite solid rather than cystic. So making a myxoid component within the lipoma or liposarcoma less likely. Okay, it's not to say never is never, but this is more in keeping with a lipoma than a liposarcoma. But like you say, I see where you're coming from. So of course, in doubt, you refer it to the surgeons to get them to take it out, or you keep an eye on it or monitor it. But I think malignant change of lipomas in the liposarcomas in children is not common. Okay, it's uncommon. So most frequently subcutaneous, but I think we got this. That's the ones that not subcutaneous. Ultrasound is very variable. It can be hyperechoic, isoechoic, hypoechoic mix, depending on the type of fat in it. And on MR, you have complete fat suppression, but you can have some septations, and you can have a little bit of a contrast enhancement as well. Okay, again, I don't think this is a topic that would be given to you in exams, because it's really more of a specialist type. Okay, yeah, I think that's the end. Yeah, so a summary of what we've covered today in the second section. I think we've covered DDH, some vascular anomalies. Just remember, it's just the age. So kids, so of course in toddlers, we didn't cover transient synovitis, but essentially it just looks like a joint effusion, often diagnosed on ultrasound. But ultrasound cannot tell you whether it's infective or reactive synovitis. So often you need clinical features to support it, whether it's transient synovitis or septic arthritis. Because of the child, okay, the transficule vessels. Birthdays, you get it in the 4 to 8 or 3 to 10. Of course, JIA happens at, anywhere under 16. Trauma, trauma. You think of the avulsion fractures, you think of the tilo fractures, the triplane fractures, your osteochondrosis or your osteonecrosis, Perthes, Penners, Freiberg's and whatnot, CNO, CRMO, lipomas can happen really in any age. And of course, all the other ages, you think of septic arthritis, pyomyositis, osteomyelitis, and what we didn't really cover today is metabolic diseases, but at least we went through some stress fractures and some insufficiency fractures. Okay, so that's the end of session 2. Sorry, this was really a whistle-stop talk of some of the pediatric MSK stuff. Feedback forms. I don't know if you've got any questions. I'm going to invite, if Geeta's still around, to join me in the Q&A.
Sure, I'm here.
Geet, do you want to add anything on the lipomas, of the pediatric lipomas?
No, nothing. I think you covered everything really nicely.
Okay. I think we've dropped quite a few people. If you've got no other questions, we're just going to we'll just wait for a few more seconds. If you've got any questions, type it out in the chat and we'll try to answer it. If not, then thank you for joining us today, and we'll see you next